All right. On behalf of the Rural Health Association of Utah, I want to welcome everybody to the July 2026 Rural Resource Webinar Series. These monthly webinars are designed to highlight practical tools and programs that rural healthcare professionals across the state of Utah may not be aware of, with the goal of strengthening rural health outcomes through greater utilization and connection. You can access the recordings and materials for this session, as well as all of our past and future sessions on our website, which is rhau.org/rhau-webinar-series. And we are continuing to build a comprehensive on-demand library that's tailored to the needs of rural healthcare in Utah. Thanks for joining us today. Your participation is what makes these webinars meaningful and worth our time. I'm very excited about today's session. We have two great programs that are going to be presenting today. The first, we'll hear from Jackson Williams. He will be sharing about Tenovi and the remote patient monitoring technology that allows patients to connect or to use connected medical devices such as blood pressure cuffs, glucose monitors, scales, and pulse oximeters from home, and then those readings are automatically transmitted to the healthcare provider without even requiring an app or Wi-Fi, which is a great tool. Following his presentation, we're going to hear from Alexandra RHAU, and she's going to be sharing about the Restoring Ancestral Winds, which is an amazing resource that's aimed to end violence in Native American communities. Super excited for both of these presentations. Let's see. We'll start off with Tenovi and go until 12:25, and then we'll move to Restoring Ancestral Winds and Alexandra after that. And I'm going to go ahead and kick over to Jackson, but I'm pleased to introduce Jackson Williams, who's Vice President of Growth and Enterprise Sales at Tenovi, a remote patient monitoring company offering FDA-cleared cellular connected devices and data infrastructures with a strong data infrastructure behind it. A major focus of his work this year has been helping rural health organizations turn their grant awards into sustainable RPM programs, translating funding into real deployments that reach low-tech, hard-to-serve populations. He works closely with FQHCs, rural health clinics, and critical access hospitals to establish remote care that fits how their team actually operates. Jackson, the time's yours, and we'll go till 12:25.
Thanks, Casey. Really appreciate the introduction. As Casey said, something that got kind of slapped on my desk and initiative for me since October, September, kind of when the RHT grants started to roll out or the information came out from CMS, was rural health transformation. Now, Tenovi's worked with a lot of rural populations in the past before rural health transformation grants come out, but when we saw them come out, we're like, man, we're pretty good at this. We've seen a lot of success working with some FQHCs and RHCs, et cetera. And that's something that was, put on my desk and said, hey, go figure this out. And so since then, I've done a lot of traveling, went to Utah back in April, was in the state of New Jersey and a couple other states as well, meeting with a lot of folks who are administering the grants, receiving the grants, et cetera. And I think the big theme or thesis that have come out of these discussions when I've met with these people in person is we are getting these grants and this money on our plate with expectations to do a lot, right? Like this is something we have never done before. It's going to be challenging. We don't even know where to start. And then we have to report back to the state and then back to CMS on all these outcomes that we're supposed to achieve with this money and this infrastructure. And we don't know how to start. And so today, really the goal for me is to take a step back and just, kind of educate the group on what remote care is, why remote care, and some of the challenges and successes we've seen in remote care. And then also just a little bit about Tenovi and how, care programs can be administered and how we can help build those for folks that are receiving funds or trying to build remote care programs for rural populations. And I kind of already ran through this, Casey. We can go to the next slide, but this is just a quick agenda for today. I wanted to just start with why remote care matters for rural populations. I think there's really two key pieces that I wanted to hit on. And this might, be like a broken record. I think most of us kind of understand this, but I think it's good to relapse some of this information. I think the big thing is, specifically in Utah, when I came out, Casey, was, a lot of patients that are considered rural in Utah, specifically being a very rural state, is patients are maybe an hour plus away from the clinic, or a critical access hospital, or even further away from their PCP. So when we think about like traveling, to a clinic to get a checkup, or something bad happens, right, to go to a critical access hospital, the access to care is definitely a burden, when we think about transportation. And a lot of patients will be like, I'm just not going to go in, right? Like, I'm not going to go receive care. And that's a main challenge, right? So how can we bring the hospital to home, so we can intervene quicker and do things like that? I think the other challenge is more of like a holistic approach to how our healthcare system is administered. I think of our healthcare system mainly being more of a reactive model than a proactive model. I, break my leg, I go to the hospital. I feel bad, I feel sick, I go to the urgent care, or I go to the ER, instead of looking at it from a lifestyle approach, tracking things on a daily basis, tracking diet, tracking medication, things like that, to actually see real outcomes, because the real outcomes come from a day-to-day, not more of a Band-Aid solution. So trying to build more of a proactive approach in our healthcare system rather than a reactive approach. I wanted to just start like what every RPM program or remote care program or connected care, however you want to describe it. I think there's three legs to the stool when I think about how you can build a remote care program. First is devices and data. You really need medical devices in home, either to track medication adherence or vital signs like blood pressure, SpO2 sat, weight, things of that nature, to be able to gauge and meet the patient where they're at, right? Understanding where they're at, so you can track how the program is actually working. The second is a platform. Where is this data going to go? How do I triage it? How do I organize it? How do I get the data and all this information in the care plan into the EHR for interoperability? That's the second piece. And then the third piece is either what I like to think of as the humans, right? Like whether that's a nurse, and I'll get more into this in the next slide, or a dietitian, or a community worker, right? Or even now, even AI is becoming a part of this to be able to administer care. There's no really single way to run a program. We're seeing more and more. I think the traditional model is, we just have nurses run the program and call patients, ask them for their vitals, ask them for their checkups. But as we've seen remote care grow and scale as a whole in the market, we're seeing different ways on how it can be administered. So obviously the traditional way has been, nurses, RNs, LPNs that are managing and administering care programs. We've even started to see models outside of that. Some of the newer models we're starting to see is nutrition-led programs through dietitians, really focusing on like lifestyle and diet and things like that. Another model that we just released with a couple partners is pharmacist-led programs. These are groups that are engaging with patients very often, right? Patients are going in for refills every 30 days. They engage a lot with their pharmacists. They typically have better relationships, and they can also use the vitals and their expertise on adjusting medications to better the patient. The last one is another new one we're starting to see a lot is paramedicine-led in-home type administered programs. So this doesn't necessarily have to be paramedics. This could be community workers. This could be nurses, boots on the ground, people in the community that know these people by name. We typically see a lot of great compliance and enroll communities in this type of workflow because they're in the home. They know the patients, they know what drives them. And compliance is usually, I'll get into that later, but is typically a hard challenge in running remote care, getting the patient to actually buy into the program. And I think with this lead program, you can get really good results just because of that relationship factor. There's a couple different programs. I mean, I think people think like when you think about remote care, like it's just hypertension, it's just heart failure, it's just diabetes. But I think it goes way beyond what you can manage for remote care. Just expanding on chronic disease itself. You can manage chronic kidney disease, obesity, weight management, things like that, even oncology. Like it really, is broad when you think about chronic disease and how you can manage programs outside the traditional four walls of the clinic. But even from there, like maternal health is a big one that I've seen written in a lot of grants in Utah in particular. Like a lot of these places are maternal deserts. Like moms don't have access to hospitals, deliver babies. They can't go into the clinic with their OB very often. We can bring the hospital to home for maternal mothers to be, able to track their blood pressure if they're at high risk, or even fetal Dopplers for the baby itself. Medication management is another one, right? We have tools to be able to build, so patients can be able to look at their medications on a real-time basis, not self-reported, and pharmacies can see that with vital signs. The other piece is hospital, home, and post-acute programs, taking really, really acute patients that are just been discharged from the hospital, and being able to bring the hospital home, manage their vitals, and bring that kind of experience that you would get inpatient, outpatient, way away from the hospital, and still feel comfortable discharging and managing them at home. I think there's a couple challenges when I think about remote care, right? Like some say like it might be easy to stand one up. Sustaining it can be difficult, getting that compliance right. Like these are all the things why people have been turned away from RPM in the past. And so I really have two best practices when I see, challenges specifically in RHAU and why compliance is a challenge for patients. I think the biggest thing is a lot of RPM starts with behavior change, right? Like we can give the best technology, we can, build the right care team and do all that, right? But a lot of it boils down to the patient. If the patient is not engaged and they don't understand why or what's in it for me, to understand why am I doing this, right? And I'll just provide an example. Like, I think about like my dad or a middle-aged person, right? That's just having grandkids. And maybe he doesn't really care about his health. Like he doesn't go to the doctor, he doesn't track, if he's diabetic, he doesn't track his glucose levels. He doesn't care, he eats how he wants, right? But maybe, looking back and peeling the onion back, it's like, hey, you just had grandkids, your grandkids, now 1 year old. Like, do you want to be able to see your grandkid grow up and be healthy enough to interact with them, see them graduate, see them get married, things like that? Maybe deep down, that's what he cares about, and that's what's going to drive him to better his health, right? Because when I think about a remote care program, we're just getting their vitals. We're tracking that. We're making it easy for you to have access to these things, but you're actually not going to see improvements in your patient's health unless they're actually bought into the program. They change their diet. They change their lifestyle. They're adherent to their medication. They're adherent to their care programs. So I think it's a really important piece, instead of just sending devices out to a list and calling the patient and saying, hey, take your blood pressure, get on the scale. That's not the workflow that you want to do to achieve, the outcomes that you're being asked to do. The better workflow is to start with why with the patient. Sit down with them on the phone, understand why they want to be part of this program, and have that be the thesis of the program, and remind them constantly. And that's how you'll actually achieve great behavior change and get compliance to the program, the outcomes that you guys are looking to get. I think the other piece I touched on briefly, the three legs of the stool, as I like to call it. I think all these things have to work together in unison, and they have to be surrounded around the right program that you're trying to build. So when we think about it from a device perspective, devices need to be easy to use, or difficult, not tech agnostic patients are not going to use them. So what does that mean? Like simply plug and play. I send you a device, I take the reading, I get the data. Easy as that. Like the devices have to be easy to use. A lot of times they need to be cellular, right? Like we're working with patients that might not have Wi-Fi, or maybe they're in dead zones. So working off of broadband connectivity, or having fallbacks when you need it, so you can actually receive the data. So I think they need to be, simple to use, and also have the connectivity to actually get the data. On the platform side, you need an easy to use platform. You need something that's going to, integrate with your EHR. When I talk to a lot of nurse teams and clinicians, they don't want to be logging into, 4 different platforms to be able to view the data. They want it all to be, if you're using Epic, for example, to go into MyChart, be able to see those vitals with the care plans that you guys are already administering, making it easy to do these things. I think the other piece is being designed on how you want to administer the program. If you're running a maternal health program, you don't want to have a platform that's meant to administer like heart failure, chronic disease, or post-acute programs. You want something that's going to be specialized to the program you're trying to build. And then lastly, you got to understand your patient population and how you want to administer with the right people. Like, do I want to use that paramedic workflow, because I have community workers that know the patients very well and they're in their home, right, all the time. And so it just makes sense to use them to monitor the program. If you want to use, more of a dietetics approach, using dietetic led programs to track weight and their diet and things of that nature, which I covered a little bit before. Lastly, I just wanted to briefly touch on Tenovi and our unique model and how we can support RHAU. I talked about the 3 pillars, I've been talking about it all day. We sit on the device side of things. So, Tenovi's specialty is connecting all these different medical devices that can be easy to use for a patient and give off great data, and making it easy to connect through one API into a platform of your choice, whether that's you're building a chronic disease program, maternal health program, medication management, post-acute, et cetera. We work with hundreds of different partners that do all kinds of different things in remote care and use our device data to be able to, put that in the EHR and make it usable for clinical staff and patients. So essentially, like when you're thinking about this, you're getting grant money, you're thinking about how to build a remote care program. Where do I start? I think we have a unique ability to, start at the tip of the spear and say, what are you trying to do? How can we help? And bring in the right partners to be able to support you guys. Casey, I know that was a little less than 20 minutes, but I wanted to.
No, you're good. There's a question in the chat box, Jackson. Do you provide services for research?
We do provide services for research. So we work in, with a lot of academic medical centers to do research projects for like medication adherence and other, certain type of conditions. But we're open to any and all programs. I think that's the value prop for us, is we're the tip of the spear when it comes to devices. We work with so many different partners and care teams that we can build specialized programs to whatever fits your needs. And if we can't, we'll refer you to the right people.
Jackson, that was my question. I'm Bailey Daniels. I work at Huntsman Cancer Institute. Thanks for the talk. This was really helpful. Do you happen to have kind of a range in terms of what the cost looks like for, I guess just like an easy example, a study that would be trying to track physical activity for people remotely?
Yeah, that's a really good question. So we have an activity watch as a part of one of our medical devices. I would say our kit ranges are, anywhere from, let's say, $70 to $100. But, then you're thinking about like, how do I get this in the EHR? What platform I want to use? That's a little bit out of our scope, but we can always help flag down the right people and get you quotes for what you're trying to build. Another thing that's interesting for oncology, we have thermometers for temperature tracking. So we have all kinds of devices to be able to track things in oncology as well. I'd love to talk more about how you're thinking about this.
Yeah, I'll connect with you. I'm not quite sure. Nothing's coming to mind right now, but I'll contact you if after I can digest this a little bit more.
Yeah, and I did put Jackson's email in the chat box. Jackson, I know it wasn't on the slide. I think that's supposed to be a button, but even on the PDF you sent, it wasn't working. So I'll probably attach that on the PDF for people viewing as well, so that they can get that information. And Jackson, how does your product potentially work together well with telehealth expansion? Because I know that's another big area in the Utah RHTP project.
Yeah, no, for sure. Thanks, Casey. I like to think, like I keep talking about Tenovi as the tip of the sphere in any remote care program. I'd like to think of us as an enabler to remote care programs, not a solution. Mm-hmm. We really, really good at running the back-end operation to procure, kit a device, send it to a patient's home, make it extremely easy for them to use, plug and play using, cellular connectivity. And when they take a reading, we get that data. We use one API to plug it in wherever it needs to go. So we have hundreds of partners we work with today. We're, can work with more partners. It's growing. Our ecosystem is ever growing on the device side and the partner side. And so when I think about telehealth and these grants that are being put out, Tenovi can be that data backbone to be able to support telehealth programs. Because if you're not getting that real-time vital medication adherence data and you're not getting a member or patient engaged from the phone, you really have no idea what's going on in their life. and you're kind of driving blind is how I like to think about it. So what we do is we fill that care gap, giving you that real time data.
Do you have any other questions? All right. Well, hearing none, we'll go ahead and switch gears now and hear from Alexandra Ray with the Restoring Ancestral Winds program. Alexandria is a tribal sexual assault response team coordinator, sexual assault nurse examiner, director of forensics for MMIR Utah, and secretary of tribal health and human services for the, I'm not going to get that name right, Alexandria. How do you say it, Alexandra?
It's the Gabrielino Shoshone Nation.
Great, in Southern California. And with a background spanning critical care and forensic medicine, she supports survivors of violence while confronting systemic inequalities that disproportionately impact the Indigenous community. In addition to her clinical experience, Alexandra is a community educator committed to prevention of violent crimes through trauma-informed and evidence-based curriculum. Her work emphasizes collaboration between healthcare providers, law enforcement, government officials, and community organizations to expedite crisis response while restoring sovereignty to survivors in native nations. Alexandria, the time's yours. We'll go till 12:50, but if you go a little short of that since we're starting early, that's not a problem either, but the time is yours.
Beautiful. I appreciate it. But yeah, as Casey said, my name is Alexandra Ray. I've had the opportunity to work in various healthcare environments as a nurse. I kind of switched gears after getting into forensics, seeing the deficits in care in marginalized communities and just response to sexual and domestic violence. Working for Ancestral Winds now as the tribal SART coordinator. I'm working primarily with rural areas. A lot of these Indigenous communities are in areas that have a lot of unique barriers to care. So Restoring Ancestral Winds, we are a tribal coalition. We're dedicated to ending violence, not just in Native communities, but we do recognize the nuances of Indigenous communities and tribal governments and how that's going to affect response to violence. So I wanted to talk about that a little bit. We provide a lot of different services. We have some Native specific services, but I do like to reiterate with these presentations that these services are available to everybody. So especially in rural communities, there are some of those intricacies that apply to everybody in rural communities, not just those that share my cultural background. So yeah, that's kind of what I wanted to go over with you guys. This is a list of our staff that we have right now. We have 2 dedicated teams to addressing sexual assault and domestic violence. We also have a 24/7 helpline. We have outreach specialists. We do a lot of like tabling throughout Utah. But yeah, those are just some of the roles that we have currently. If you want any of their information, just reach out to me. So our mission statement, I always like to open with that. So Restoring Ancestral Winds' purpose is to end violence in Native communities. We support healing, we'll advocate for healthy relationships, educate communities on issues surrounding stalking, domestic violence, sexual violence, dating, and family violence, collaborate with Great Basin community members, and honor and strengthen traditional values of all of our relations. So I like to point out that obviously different tribal communities have very different cultural and social constructs and needs. So that's why we put in there all of our relations. Because I think sometimes Indigenous communities are kind of generalized. So the first thing that I wanted to talk about is training and education. For those of you that work in any kind of like rural patient facing or survivor facing roles, you'll notice there are nuances that don't really reflect sometimes in our protocols, whether that be in healthcare, law enforcement, or the judicial system. So one thing that we do at Restoring Ancestral Winds is we provide education for law enforcement and healthcare providers on how to exercise in a more like trauma-informed and culturally competent way. So yeah, as this slide says, we provide trainings to tribal agencies, victims advocates, tribal healthcare providers, and we hold conferences every year. We just had our annual conference this last week, but we have something called RHAU Club, which is, it stands for Restoring Our Communities. We have it every month. It's open to everybody, but that is just an opportunity to engage the community in education as well. So we'll normally, we always provide food and activities and things like that, just because some of these topics can be hard to digest. We want to increase the frequency of dialogue surrounding violence. Working in forensics, I've learned that that is the best preventative medicine, because these things do thrive in that gray area, in the stigma and the silence of not wanting to talk about it. So Restoring Our Communities engages youth, adolescents, adults, elders, and anyone else that wants to learn more about those unique barriers to the Indigenous community in receiving care. We are working on a 40-hour Native victim advocacy training as well. And one of the things that I am doing this year is I have a training down in Montezuma Creek with UNHS, Navajo Health Services. If any of you guys are interested in that, just let me know. We'll be going over some different SART coordination roles. We're going to run through some scenarios for sane situations, survivors that are Native, non-Native, LGBTQ, juvenile. So if those are areas that you're interested in learning more about, just let me know. I can get you more information about it. But that is a big part of my role as a SART coordinator, is also providing education on jurisdictional complexities, navigating like tribal governments in those moments of crisis. I think that's something that really delays care right now, is sometimes law enforcement or healthcare providers aren't really sure what those jurisdictional boundaries are, and they're having to figure that out in real time instead of already being equipped with that knowledge. So that's a deficit that I'm working to mitigate. So this slide just kind of goes over some of our accolades and things that we do in the community. We partner with UCASA, the Utah Coalition Against Sexual Assault, and UDVC. We're working with them on a advocacy training as well, tribal cat training. I believe that is going to be finalized next year. Yeah, we're a member of the National Alliance of Coalitions to End Violence. I talked a little bit about policy recommendations that we provide to different agencies throughout the state of Utah. And obviously, yeah, we advocate for victim services in tribal nations. So another thing that we do is provide technical assistance. Like I said, tribal jurisdiction can be really difficult to navigate, and it's not specific to just rural areas in Utah, but you're going to encounter that a lot more frequently. So that is why in my role, that's the demographic I'm working with most is law enforcement and healthcare providers in rural areas, rural hospitals, especially navigating those tricky jurisdictional intricacies. And if that's something that you guys have questions about, I'd love to be a resource for that as well. I know it's very involved and ever changing. It's always evolving too. So I don't think there's going to come a time where all of us are on the same page and it's not going to change again. So that requires like continued education from that like jurisdictional standpoint. We assist the 8 federally recognized tribes in Utah. And I realize as well, being Indigenous myself, not being from a federally recognized tribe, sometimes those that are not federally recognized have even less resources. So we're also assisting any Indigenous nations. So we collaborate with the Navajo Nation, Paiute, Ute, Mountain Ute, and Shoshone on federal policy and tribal code on domestic violence. And again, we provide culturally specific training to support urban and rural community partners. So we do work not just in southern Utah, northern Utah, urban areas as well. We are located in Sandy, Utah right now, our offices. I'm in Provo. We kind of have our staff all over Utah and Salt Lake counties, but this role does require commuting to rural areas, which I am happy and love to do. So we can go to the next slide too. There you go. So our helpline, we have someone there Monday through Friday on our line. But people can reach us 24/7 through this number, and we can redirect as well if somebody isn't available. So what we do is we can create safety plans, do like assessments on risk. We provide personalized mental health and violence prevention, safety planning. So what you'll find too in Native or rural communities, it's not as simple as like just recommending like, oh, you should remove yourself from that situation. It's important to recognize those geographical barriers that might keep somebody in a dangerous situation and how to create a safety plan that accommodates those barriers that are pretty common out there. Some people don't have transportation at all. Some people don't have access to hospitals. Like Jackson was saying, some of the communities I'm working with, like they're going to have to drive a couple hours to receive medical care. And a lot of people aren't willing to do that. And in some cases, their access to healthcare is limited to things like this. So we kind of take that into account when we're interacting with people that are in crisis. We can help involve different agencies if that's something that is wanted. But with survivors, one of the things that I like to point out and that I learned through being a sexual assault nurse examiner is we want to reinstate that autonomy that was taken in whatever sense we can. So if somebody is coming to you that has been assaulted or has been in a domestic violence situation and that autonomy had been stripped from them for any amount of time, I like to reiterate to survivors, like this is, you get to decide how this conversation goes. Like I want to reintegrate that sovereignty wherever I can. So even if that's just providing referrals to resources, that's something that we can do. And this helpline isn't just for Natives. we like to put that on here because I think sometimes in these tribal communities, there is a generalized distrust of agencies. So that kind of reduces that barrier in seeking help, knowing that they're being connected with people that are culturally competent and likely share their cultural background. But this is available to everybody, and we do get calls from non-natives. But I also like to reiterate to those in this presentation, like those apprehensions that natives or people, non-natives in rural communities, that distrust or trepidation in involving law enforcement or different healthcare providers isn't a personal deficit. That is an appropriate response to the systemic issues and geographical complications that they've experienced. So I try to tell people not to like take that personally. Like that's an appropriate response to the barriers that they've experienced. Like I said, we have after hours support as well. So if somebody calls at a time when one of us is not available, we can redirect to another native helpline. And we do provide help with like legal information as well. That is something that's pretty complex, especially for somebody that just experienced a traumatic event. Navigating the judicial system and the healthcare system is not very therapeutic. So that's something that we can assist with as well. These are things that I talked about on the last slide that help reduce that apprehension in speaking with healthcare providers and advocates, and why we keep that like native in the helpline. We're implying that we are aware of the effects of that intergenerational trauma that shape those opinions and biases that they have. We recognize that native sovereignty and self-determination. We recognize some cultural aspects that I know as a nurse they didn't talk about in school. A lot of healthcare providers aren't equipped with that knowledge. And I don't think that comes from a malicious place. I think there's just a lack of education and dialogue on the difficulties experienced by rural communities. And that's why I'm here talking about it. We do work with a lot of the LGBTQ and Two-Spirit community. We want to empower women, non-binary, and Two-Spirit people, and encourage traditional healing practices. That's one of the things that I love about this role. I want to kind of marry that clinical experience and knowledge that I have and traditional healing practices, because ultimately, sometimes in these rural communities, that is what they have access to, are those holistic healing practices and ceremony. And I want to acknowledge that as a part of that care plan. So yes, we have a commitment to confidentiality. We create safety plans. We actually just went live this week with a new program for our helpline that includes texting, which is huge for people that might be experiencing intimate partner violence. They might not be in an environment that is safe to have a verbal conversation with somebody. And I think that is something that some helplines might not acknowledge or be able to accommodate. We can connect them with resources. As a SART coordinator, one of my roles is being a conduit of information between agencies and different areas. So if you guys have any resources for survivors in rural areas, I would love to connect. I'm creating kind of like a master list. so we can expand the resources that we're providing to people and be even more specific with their needs. But yeah, we also provide education. So even if somebody walks away from that conversation, even with a greater understanding of what is available to them, or that they have opportunities for support, even if they are in a place where they can receive it, that is a measure of success for us. Because you'll find, especially if you guys work in a role that is survivor facing, or you have personal experience or know of somebody, sometimes the first time someone's presented with a resource, they may not utilize it because of those trepidations I talked about earlier. But I don't want one of the things impeding someone from receiving care to be just not knowing what to do or who to go to. So that is what you can expect from the helpline. So this kind of just goes over what I've already talked about, what our role is in the community. And I kind of want to change the verbiage on this slide after this, because I don't think of it as like partnering with RHAU is like a business enmeshment. I want to be a resource for people. So even if it's like redirecting somebody to our services, or like we can be an information hub. So if you have an Indigenous survivor, relative, friend, family member that is in crisis, I tell people, like, if you don't feel equipped or qualified to navigate that conversation, we can step in and help with that. So like I said, we bring together the Indigenous communities and state and federal institutions. We provide training that isn't just for service providers, but also community members as well, because sometimes in these rural areas, those relationships that people have out there, that's the resource that they have. So we also want to provide education to those that are like on the ground in the community, the ones that are that safe person for somebody. We want to equip as many people as we can with the knowledge on how to respond to violence, because a lot of times survivors, their first disclosure isn't going to be to law enforcement. It's going to be to a friend or a family member or somebody that might not feel, again, qualified to navigate that conversation. We want to equip as many people as we can with that knowledge on how to respond in a trauma-informed and culturally competent way, both in those community relationships and agency-wide. But yeah, I think I covered most of what's on this slide. These are some different resources and entities that we work with. There's crisis centers and other helplines across the state of Utah that we partner with as well. So some of these other crisis lines with Indigenous survivors, they might redirect them to us as well. And that's kind of the goal, and why I want to get this information out to healthcare providers as well. Like if you are a nurse or a first responder and you are interacting with somebody from one of these communities, again, whether they're native or not, a lot of people in rural areas share the very similar barriers. We can help with that. It's not something you have to navigate by yourself. But yeah, those are some resources. If you need or want more, that's something that I can provide to you as well. And yeah, this is the contact information. Mine is at the bottom. Again, my name is Alexandra Ray. I'm the Tribal Sexual Assault Response Team Coordinator. These are other educators as well. Amanda Miller is our executive director. And yeah, the best way to get a hold of me would be over email. My phone number is on there as well if you'd like to connect. Yeah, does anyone have any questions? I know it's a lot of information. I could talk about this for a while.
Hi, my name's Holly. I'm so sorry I joined late. I was really looking forward to this presentation, and the short little bit I caught was absolutely fantastic. So I'm so glad that I was able to catch some of it. And the recording, is that
It'll be sent out. Yeah.
Awesome? Thank you. Because yeah, I can already think of a million questions, and you probably already covered them. But I would love to connect more too. I work with multicultural and disability, with mental health therapy and rural networking, and I'm trying to create a spreadsheet of some sort too, with lots of different. So I would love to connect and share what resources we have with each other.
Yeah, that's amazing. I would love that. Yeah, as you know, these roles are pretty like niche, right? But in these communities and rural areas, as you guys know, being a part of this webinar series, you probably work in this realm to some degree. It's needed. Even just I tell people too, I measure success by even one agency connecting can make a huge difference in the healing process of an entire community. So I love doing these. Like I love connecting with people, and I appreciate you tuning in, especially on a Thursday afternoon. I tell people electing to these conversations where you know it can be potentially uncomfortable. And it's difficult information to hear too, just the subject matter to navigate. I appreciate it. It's not lost on me that you guys are electing to be here, and it's important conversations and dialogue that we're having.
We appreciate you making the time to come and present this information and help us get this out to our members as well, Alexandra.
Of course, I appreciate the opportunity, you guys.
Do you have any other questions before we wrap up? Okay, hearing none. As we're wrapping up, we just want to highlight that our annual RHAU conference is coming up in November. The Rural Health Association of Utah Conference is the premier gathering dedicated to advancing rural health in Utah. We'd love to have you come join us. We have healthcare leaders, providers, policymakers, and advocates that come together for this conference. We should have around 400 people there this year. And it's in St. George, November 4th and 5th. And this year's theme is Stronger Together, United for Rural Health Transformation. So really want to get everybody together, and as we look at where we're at after 1 year of rural health transformation in the state, where we'll be heading to after that. And just wrapping up, we will meet again in August. Our next session's August 6th. We're going to hear from Gibson Insurance during that session. Nick Hansen will be discussing risk management strategies in corporate insurance. And then we'll also have Rob Entz from the Utah Commission on Aging, who's going to speak a little bit about trends in aging and rural healthcare and some of the impacts of the rural healthcare program there as well. You can RSVP for the August session by scanning the QR code on the screen or by visiting our website. The recording from this month, as well as the slides and all of the previous recordings and slides, will be available on that same webpage. And then we are still looking for a couple more speakers for 2026. We have a few openings later this fall. August and September are full, but we're looking for a few speakers for October, November, and December. So if you have any questions, please reach out to us. Our email is info@rhau.org, and we appreciate everybody taking the time to attend today. Wish you all a happy 4th of July. And hopefully everybody has a safe and enjoyable weekend, and we look forward to seeing you next month.
Thanks, everyone.
Yeah, thank you guys so much.